Good afternoon and welcome to the University of Melbourne's final online MedTech webinar for 2025. It's proudly hosted by the MedTech platform led by the Graham Clark Institute for Biomedical Engineering. We're delighted to have you join us today. My name is Vijay Rajagopal. I'm an associate professor at the University of Melbourne in the Department of Biomedical Engineering. I'm also the theme lead for digital health and simulation technologies at the Graham Clark Institute for Biomedical Engineering. And personally, I'm passionate about using digital health simulation technologies to advance fundamental understanding of cardiovascular biology and to find new treatments that are effective for cardiovascular diseases. So I'm really, it's my pleasure today to be your MC for this webinar panel discussion. So today our theme is to discuss digital health technologies in cardiovascular medicine. We're going to discuss the success stories and the opportunities. And I hope you enjoy this discussion with our panel experts. But before we begin, I'd like to make an acknowledgement of country. I'd like to start by acknowledging the traditional owners of the land from which I'm hosting this webinar, the Wurundjeri people of the Kulin Nation, and pay my respects to elders past and present. The MedTech webinar series, of which this is one, runs twice annually. And in our last webinar, we had people discuss how sensors, biosensor technology is reshaping the way we think about health and disease. And these webinars are basically our way of showcasing the advanced research that's happening, not just at the University of Melbourne, but also amongst our collaborators and our close friends. Speaking of these webinars, you can watch these webinars in case you've missed them. You can watch them by going to the Graham Clark Institute website or any of the other Faculty of Engineering websites where these webinars have been recorded and hosted. And indeed, this webinar itself is being recorded, and the video will be put on the university's Faculty of Engineering and Information Technology webpage. I'd also like to introduce everyone to our illustrator, Alice, who will be scribing today's discussion. Hello, Alice. I'm waiting for that. There she is. Thank you. Thank you for joining us today. I'm really looking forward to seeing what you capture with your cartoons today. So, having set the scene, having made the necessary introductions, let me now let's dig into the topic of the webinar today. So today's topic is about cardiovascular disease and digital health technologies. Cardiovascular disease is the leading cause of death in Australia and worldwide, and its incidence continues to rise with an aging population. Effective treatments are urgently needed, yet recovery for cardiovascular events are often complicated by comorbidities like kidney disease or diabetes, and also hospital-acquired infections. These challenges are placing pressures on our healthcare system and highlight the need for solutions that are both cost-effective and time-efficient. The panel today will explore the advances in a particular area of cardiovascular technologies, which is digital health technologies, and how they're helping with cardiovascular care. Digital health technologies is a broad term that incorporates things like wearables, digital twin simulations of cardiac physiology or vascular physiology, and also digital infrastructure for data, patient records, and things like that. So it's a pretty broad topic, but we will, with our panel, discuss a few of the exciting opportunities that, at least among the panel members, we'll get a sense of today. Finally, so before I start introducing our panel members, I want to thank you all for joining us today. You're welcome to interact by typing questions for our speakers in the Q&A box to your right-hand side. Some of you have submitted questions via the registration form, but should our conversation spark further thoughts or questions, I encourage you to engage with the panel through writing new questions or liking the ones you want answered. It is the whole topic of cardiovascular disease and digital health technologies. It's a pretty big topic, and we don't have more than about an hour to discuss this. So we do apologize if we don't answer all of your questions, but we do hope and will attempt to address them, as many of them as we can. So with that, let me now introduce our speakers, our panel members today. To begin with, I'd like to introduce our first panel member, Vicky Edwards.
Hi, BJ.
Hi, Vicky. Thanks for joining us.
Thanks,
Vicky. Great. Vicky has more than 25 years of health technology industry expertise. She brings cardiothoracic clinical experience and a deep commercial capability and understanding of how to successfully bring new interventional technologies for cardiac care to the market. Her broad capabilities across sales, marketing, field operations, patient care, and regulatory affairs add immense value to Hydrix Medical, the company where Vicky is employed, as they deliver a portfolio of products and technologies in the Asia-Pacific market. Thank you, Vicky, for joining us today.
Thank you.
Our next speaker, our panelist, is going to be Professor Peter Barlas.
Thank you, Vijay. Great to be with you.
Thank you so much for joining us. After graduating from the University of Melbourne, Professor Peter Barlas trained at Austin Health and completed a Master of Public Health at Monash University and undertook a fellowship at the Royal Brompton Hospital, London, followed by a PhD at Erasmus University, Netherlands. His PhD was on optical coherence tomography in cardiology, and he led the optical coherence tomography adoption across over 60 centres in Australia and New Zealand, and is internationally known for his work in interventional cardiology, advanced coronary imaging, and novel cardiovascular therapies. A fellow of multiple international cardiology societies, Professor Peter Barlas has authored 3 textbooks, 10 book chapters, and over 130 peer-reviewed papers in his areas of expertise. He leads a biomedical engineering research group developing new imaging and cardiac devices, including 3D printing, and serves on several editorial boards. Thanks, Peter, for joining us.
Thanks, Vijay.
And finally, I'd like to introduce everyone to Associate Professor Lachlan Miles.
Hello, Vijay. Great to see you.
Hey, Lockie. How you going? Thank you so much for joining us.
No worries.
Lachlan is a staff specialist and head of research in the Department of Anesthesia at Austin Health, an honorary principal fellow of the Department of Critical Care at the University of Melbourne, and an honorary principal research fellow and perioperative clinical lead in the preclinical critical care unit of the Florey Institute of Neuroscience and Mental Health. His subspecialty clinical practice involves cardiothoracic and major hepatobiliary anesthesia, including liver transplants and perioperative medicine. Thank you for joining us, Lachlan.
Thanks, Vijay.
Great. So welcome, everyone. Thank you again, and let's get started. I think for the benefit of the audience today who have joined us, I think it'd be really good to set the scene by first discussing the burden of cardiovascular disease. Peter, maybe you could start us off on that.
Thanks, Vijay. Look, no doubt this is all a very important topic. Heart disease has probably touched many of us, and I see it as a practicing cardiologist. I work as an interventional cardiologist, and that is a cardiologist that manages patients with these little stent devices, and that's essentially 24/7 being available to treat patients with acute heart attacks. And that's perhaps one of the more feared cardiovascular diseases, an acute heart attack. But it's really an umbrella term that refers to any disorder or condition that affects the heart, the blood vessels, affects the heart itself, the brain. Leading cause of cardiovascular disease is stroke and heart disease. The statistics are sobering, but nonetheless, They are pretty dismal. And I guess when you look at 120 people die in Australia each day, and it's an enormous number, and one person every 12 minutes dies. And I see it, and I see the deaths, and I see the disability that this condition brings forward. And not only does it affect patients, but it affects their loved ones as well. And then they are unable to work. Somebody comes in. Just last week, I managed a patient in their early 50s who had a significant heart attack. This person was an executive, and now obviously is having major concentration issues. Medications are becoming a problem, unable to work. And it has a huge impact not only on the patient, but also on the family and community, and also economic impact with, less ability to work, participate in the workforce. So it's a major, major challenge.
Lachlan, I might actually ask you a follow-up question that I think touches upon what Peter was mentioning. Maybe you could tell us a little bit about how, what kinds of diseases are early signs that we don't, there's that feeling that heart attack is a serious one, but there are things that happen beforehand that lead up to that, or you don't know that have led up to that. Maybe you can talk a little bit about that so that people are aware that it's not just this surprise event that happens.
Yeah, absolutely, Vijay. And you raise a very important point. And in my area of practice, which is anesthesia, and in the perioperative space, we can broadly divide these into two categories. Now, the first category is one that Peter has already touched on, overt cardiovascular disease. And whilst I don't assist Peter and his colleagues in the catheter laboratory, when they have coronary artery disease, which is not amenable to the stent devices that Peter spoke about, we usually come forward to the operating theatre. We do formal coronary artery bypass grafting. So I deal with those patients on a daily basis. In my practice, though, there is actually a far greater problem, which you've alluded to very briefly, which is this concept of silent or hidden ischemia. And these are events that patients may not even know that are happening. And we tend to see them in patients who are elderly, in patients who have other risk factors such as diabetes or high blood pressure. And in the perioperative space, these are patients who are walking around living their day-to-day lives. There are no problems whatsoever. But if they have an operation or a great stressor in their life, these then can become apparent. And there's actually a term for this in the perioperative space, which is myocardial injury after non-cardiac surgery. Now, these events are problematic for two reasons. The first is that they're common. They affect about 5 to 10% of all patients after major surgery. And the second problem is 93% of patients who have one of these episodes have no idea that they're having them. So you might be at home, you get chest pain, shortness of breath, pain radiating to the jaw down the left arm. You say, this is a problem. You call an ambulance, you go to hospital, you meet Peter. On the other hand, the events that I'm talking about are completely undetected unless you actually go looking for them with blood-based biomarkers. And if you have one of these events after major non-cardiac surgery, they increase your risk of mortality roughly 23-fold. So these are major unrecognized clinical problems that nevertheless exist along the spectrum of cardiovascular disease that Peter was talking about. But what Peter deals with is largely at one end, and what I deal with is largely at the other end.
Mm-hmm. Right. And when you both alluded to like age as a factor, and before we started this webinar, when we were preparing for this, Peter, you were mentioning that you do see younger people with coming to the clinic as well. Maybe you can talk about how aging and how it's not even about aging, it's maybe even lifestyle and aging is changing who you see in the clinic.
Correct, Vijay, correct. No doubt outcomes after acute heart attack have improved. Our stent devices are getting safer. Our pharmacotherapy has been instrumental at improving outcomes and thinning blood with certain drugs that we use and lowering cholesterol with statins and managing blood pressure. But we are seeing, I'm seeing in my practice day to day, younger patients presenting with cardiovascular disease. And the challenges there are particularly genetic factors. So there are genetic factors that predispose us to building up plaque, or what we call atherosclerosis, and that is these fatty deposits in the arteries that affect the heart, but also the major risk factors that we're seeing of high blood pressure, obesity, diabetes. Obesity, and as we've all probably seen in the lay press about all these new drugs and the Ozempics and the impact they're having, but the challenge is immense. Obesity leads to significant issues with high blood pressure, higher risk of diabetes, higher risk of obstructive sleep apnea, another very important but under-recognised condition that contributes to cardiovascular events. And as a result, we are seeing younger patients, and that means that these younger patients are living longer with the consequences of heart disease. And therefore, the chronicity or the chronic nature of heart disease, and as Lockie said, I tend to manage the acute problem when somebody comes in hospital with a heart attack, but I look after them for many years later, and it's managing those issues longer term are major challenges still. Heart failure, we might have heard of a condition whereby the heart muscle becomes quite weak. Well, that also leads to not only disability, inability to work, but also recurrent hospitalizations. And that's a major, major challenge.
Right. I want to bring Vicky into this conversation now. And Vicky, you work at Hydrix Medical, and it would be good to introduce what Hydrix Medical does, and also then talk about what is, and since it is about digital health solutions, maybe you could also then talk about what Hydrix Medical does in that space, but also the wider term digital health technology. What does it mean to you?
Yeah, sure, Vijay. Thank you. Hydrix Medical is based in Melbourne, primarily a design and product development company. So we have a large group of engineers of various disciplines that work with a range of companies and personal cardiologists, vascular surgeons, to develop solutions, not only digital solutions, but also implant, active implantable devices, etc., to help solve some of the problems that we see in healthcare. Predominantly, we do a lot of work in the cardiac space, certainly in the MCS space as well, with LVADs and artificial hearts, but we do a range of product development and work with a range of companies. From the digital health perspective, currently we work in the cardiovascular space, so looking at digital health technologies and looking to take those to market. But I think digital health as a wider descriptor really encompasses a lot of areas. And, you're looking, as you mentioned, we're talking about simple wearables like Apple Watches, all of those, Samsung watches, etc., to medical type devices. But then there's other areas of digital health that are less known. For example, electronic medication management, the electronic health record, obviously, a lot of people have heard about, which is our personal health record that we have access to. But then there's also the electronic medical record, which sits inside the hospital system and the healthcare system that provides details and continuity of information for clinicians. But even wider than that, the plethora of data that's available from digital platforms now is just phenomenal, and it just allows better care. It allows a lot of data for research, and now with the term of AI, or some call it machine learning, to actually be able to run over that data and look to solutions or find patterns in disease that allow the clinicians to look further into treatments. And then just simply at a patient level, the number of apps that are being developed both by hospitals and commercial entities that allow them to manage their diseases better, manage their medications better, their symptoms better, or just provide health advice. The spectrum is massive across the range. So, and I think the nice thing about digital health technologies is the more data you have, the better you can understand it. It allows our cardiologists and our researchers to investigate better care and better follow-up, and just provides us with such a huge opportunity to improve healthcare and clinical care across not only Australia but globally as well, across populations. So digital health is just, I think, a huge opportunity across the spectrum for everyone.
With the people that you're talking to about potential clients or potential clinicians that you collaborate with, what are the typical? Are there some specific pain points that they want to address? What's the most common ones that that the company's identified?
I think there's a range depending on the technology that's available. It's great to have data, but too much data also then gets quite difficult to handle and understand. So I think the ability for people to look at data sets and be able to make sense of those data sets. A lot of people in the health area talk about interoperability, so the ability to actually access the data and be able to combine data across platforms, whether that be the electronic medical record or into a patient app that makes sense. Cost is another aspect, and most of these data sets are now cloud-based, and it comes with a certain cost to the healthcare system, and we all know the healthcare system kind of is lacking in resources from a funding perspective, so that makes it difficult to be able to provide the solutions in a cost-effective method. And then change management, which is also a bigger area, trying to implement platforms and changing the way people actually interface with information, how they use it in clinical care, etc. So there's a number. And then from a community perspective, I think the biggest thing is, health equity, access to data, access to platforms, being able to introduce technologies into rural and remote areas where perhaps internet access is not as great, or whether health literacy or access to digital platforms just isn't available as yet. So we need to address that space as well. And I think, and just in the remote and rural area, that's probably where the biggest bang for buck is with digital technology and access to patients and being able to reach patients from a health perspective. That's a huge area. Yeah.
Lachlan, I want to kind of touch upon something that Vicky just raised, which is about the access to data, the sharing of data, and this desire to go to, desire is probably the wrong word, but this potential to make rural healthcare more cost effective and just effective for the patient. What do you see as working in critical care? Maybe you could introduce a little bit about what it means to be in critical care and what it means for cardiovascular disease or function, at least in critical care. And what do you think the challenges are in getting to this ability to share data across platforms?
So there's, within the critical care space, this can broadly be discussed as sort of a series of 3 orphan subspecialties, which don't really fit very well into medicine or surgery or gynecology or pediatrics. And broadly, we talk about anesthesia and perioperative medicine, we talk about intensive care, and we talk about emergency medicine. And much of the work that's been done in this space in terms of digital health solutions tends to be in patient monitoring. Now, the objective of any form of patient monitoring is twofold. It's prediction and prevention. So can we predict on the basis of a patient's vital signs, for example, whether or not they're likely to develop a cardiovascular event? And then is there a way, having predicted that event, that we can intervene and try and prevent that event from occurring? And this is a problem which is consistent within rural and within rural health environments, within sort of primary healthcare, but also within sort of advanced secondary or tertiary level facilities where we look after patients who are very, very unwell, or whether or not they're having major surgery. Now, one of the major challenges that we've got, and again, you've alluded to this, VJ, is the sharing of data. And the issue when we try and devise these digital health solutions, particularly those that use algorithms, machine learning, computational modeling, those that use artificial intelligence, is that it requires a vast amount of data in order to be able to train these models to yield an outcome that we're interested in. And what do I mean by an outcome that we're interested in? It's an outcome that ideally improves patient health outcomes. And by a patient health outcome, I mean something that means something to the patient. So I can say to you, VJ, I'm going to fix your blood pressure, or alternatively, VJ, I'm going to prevent you from having a heart attack. Now, out of those two, you don't probably care that much about what your blood pressure is on a day-to-day basis, but you care very much about having a heart attack. So just because I fix your blood pressure in the operating theatre, I need to then show that that is linked to an outcome which matters to you, but also matters to my bosses, which is cost effective, that does not result in an enormous amount of expenditure on a very small difference in terms of overall outcomes. Because at the end of the day, we're utilitarians. We need to have a view on what's happening on a health system level, as well as the patient that's individually in front of us. Now, I alluded a second ago to the idea of big data, and there is a creative tension here. We need an enormous amount of anonymized, de-identified data to train these algorithms and also link them to patient outcomes. But at the same time, each individual patient has a right to say what happens to their individual healthcare data. Now, it may be well and good for me to approach 20 or 30 patients and ask them for their permission to use their data, but we're talking about tens, hundreds of thousands of patients that we need to feed data into. And it's simply not feasible for us to approach every single one of those patients and seek prospective consent. Now, I don't know what the answer to this question is. On the one hand, I care very much about what someone does to my data, but on the other hand, I would very much like to use this anonymized, de-identified data to improve overall patient health outcomes. It kind of comes down to a philosophical balance, whether or not you're a utilitarian, the greatest good for the greatest number, or whether you're very invested in individual autonomy. Either way, this is a problem that our privacy legislation is not really equipped to deal with, and will need to be something that's solved on the policy level, I think, before we can start using it, particularly when it comes to sending data overseas.
I might just throw a bit of a spanner in the works, or with an analogy here. You know, like how we are a little uncomfortable about sharing our personal data on Google and all the shopping websites. We also don't like it when it's figured out that this is the average typical thing that you look at, even if with a TikTok, YouTube video type thing. It's like you just keep getting these predicted outputs of what it thinks you need. That could be quite nerve-wracking as a patient who feels like, is this really individualized right now? Because you're just collecting a lot of data and you're just making a prediction without really thinking about me as the individual.
And that's a really great point, VJ. And this is something that Peter and I face every day in our clinical practice. Peter and I are both heavily evidence-driven clinicians. We believe in large randomized trials, but of course, you then take this large randomized trial and you need to take the lessons from that trial and apply it to the individual in front of you. You might have a 300,000 patient randomized trial, which is very common in Peter's field. The cardiologists are spectacular at running these very, very large trials. We're not so good at it in critical care because perhaps we have a smaller recruitment base. But we homogenize these patients within the database, don't we? And we assume that everybody within the database had the exact same outcome in the trial, and we try and then homogenize the outcome of the trial. The only answer to this problem is more individualized data points from more individuals being inserted into the models. And for that, we need big data, and we need to train these models. An analogy is looking at it like a self-driving car, okay? Do you think that Waymo just took a car and said, all right, off you go, have fun? They don't. They train these algorithms on hours and hours and hours of individual driving data so that they know how to react in individual different scenarios. Now, we need to do the same thing in our large database models when we're using computational modeling or AI. We need to have that quantum of knowledge so that when an algorithm sees something, it says, I've seen that before, and I can make a reasonable prediction on how this patient is likely to react. Now, it's a well-stated maxim that all models are wrong, but some are useful. And in terms of utility, we need to ensure accuracy, but there always must be a human involved in the system. This is not a self-driving car. This is not a closed loop. So there always needs to be somebody involved in interpreting these data, determining whether or not they think it's relevant to the clinical situation in front of them, and then instituting the suggested management if your algorithm allows for suggested management.
Peter, I'd like to get your learn a little bit about your experience with digital twin technology. Well, yeah, digital health technologies, but particularly,
Yeah.
the types of technologies that you've used, and maybe you can kind of tell us about this sort of murky boundary between AI and sort of
Yeah.
these.
Absolutely, VJ. I mean, you raised a point there following what Lockie said about the data is great and digital technologies are wonderful, but we do get nervous about, what data we're sharing, and I guess security breaches of our data become even more problematic. And just one example I'll give you with, how patients have changed in the way that they feel towards digital health technologies. Patients who have had a pacemaker, for example. Traditionally, they would go to the clinic every 6 months and have a pacemaker check with a device that is placed over their pacemaker, and then the technician and the doctor will make an assessment. Nowadays, pacemaker checks are done all remotely from home. So you have a pacemaker, you are sent home a little wireless box that sits at the end of your bed, and the team tell you, look, this is wonderful. Every night, your doctor and the company that your pacemaker belongs to is receiving your data, and we can adjust anything that might be necessary. Now, that's exciting. That's wonderful, but it's very scary. And many patients are still very, very hesitant about, well, what are you doing with all this digital, technology, and how safe is it? So that's really a major, major challenge. Vicky also raised the issue of rural health and how these technologies might impact rural health. I work in obviously metropolitan Melbourne, but I have clinics in Swan Hill. I got 4.5 hours away. I'm in South Gippsland, also in Foster and Bendigo, and that is a major, major challenge. Now we're looking at these wearable technologies. There are 30-day heart monitors that are called heart bugs that can connect with a smartphone through Bluetooth, and that instantaneously transmits heart rate and rhythm information to us. So that's been a major, major game changer. We have implantable recorders that are little chips the size of a AAA battery that get injected under the skin. These can last for about 3 to 4 years in battery and are suitable for patients who have had a possible faint, a blackout that potentially could be cardiac or might be at high risk of a condition known as atrial fibrillation, an irregularity of the heart rate. Well, that again has also been a game changer in the way we manage our patients, because we can instantaneously detect whether a patient is going into atrial fibrillation and, of course, potentially prevent a significant stroke. So without these technologies, we will not be able to identify these particular patients.
Yeah. Vicky, so data seems, we've talked a lot about data and security of the data, the nervousness of patients about the data. So what have been some practical solutions that have been developed in this space?
Yeah, look, I think all of the companies are looking at, significant levels of security across the globe. Healthcare is driven by things such as HIPAA in the US, the GDPR, standard GDPR rules out of Europe, which are pretty stringent as well. And IT groups in hospitals are also very diligent with the security around the solutions that are being presented to them. And so, like recently, I was doing some work in Singapore, and we went through close to 12 months of IT question and answer on the platform that we were talking about, and looking at all of the security aspects and the what ifs and what happens to the data and who gives permission and how and all that sort of thing. So, everyone's looking at the privacy and the security side, especially when you get, in Australia at the moment, we've had a number of data breaches, with different commercial entities outside of healthcare. So everyone is really nervous, and the companies really work hard to ensure that the security and privacy are in place. And then working with cloud such as AWS and Azure, which are the two main ones that we use here in Australia, their security levels and their fundamental work insecurity as well. It is all aimed at maintaining that security and privacy and ensuring that data is secure. I think the other thing Lachlan mentioned is de-identification of data. So if you're looking, certain things, Peter alluded to remote monitoring and heartbug, you need to have a degree of patient ID to be able to report on that information, or to be able to access the information and talk to the patient about something that you've seen. But when you're looking at the large data sets that we're using, for example, in the echocardiogram space, there's a massive Australian data set, and that's de-identified data of echocardiograms that can be used for algorithm development and research and development of AI, if that's the case. And so I think it depends on the use case. In some instances, from a personalised perspective, you do need to be able to identify the patient and the data associated. But when you're looking at big data and you're looking at these massive data sets, the data can be de-identified. It doesn't need to be down to individual. It can just be used en masse. And I think that's one of the things that we're looking at, is de-identifying data and pulling it into a major data set, whether that be for a data set that belongs to a hospital and a hospital group who want to look at post-op complications or return to hospital or whatever the case may be, or whether it's larger data sets where we're looking at echocardiograms for AI, or we're looking at medication management, or whatever the case. So it really comes down to the use case.
But these data sets that you're accessing, are they set up by the hospital in agreement with you, or is it something that they're collected? Is there a one-to-one agreement before such a data set is collected, or are we looking at some government initiative that's collected that data?
So for the ones that we currently deal with, so we work in the remote monitoring space for pacemakers and implants that Peter was alluding to. That permission is given at patient level to the hospital and the cardiologist, and then the hospital, and then that data is shared to the manufacturer's site, which then under license can be used for monitoring. Right, that's part of the agreement with the patient. Other data sets, the echocardiogram data set that I talk about, that data set is a large national data set. And that has been licensed to companies, or one company that I know of that can use the data set that's full of de-identified data. So it's really up to how the data is shared from the source and what parameters are put in place at that point. I think also I understand that in the US, some of the bigger organisations, and Lachlan and Peter may know more about this, is part of being admitted to hospital is a consent that your de-identified data can be added to the hospital data pool or data lake to be used for research purposes, etc. And maybe Peter or Lockie can talk more about that space. So there's different levels of it.
Yeah. I have to say, I'm really enjoying a deep dive into data and how to store it and how to share it. But we are getting towards the live Q&A session of our time. I had many more questions that we didn't even get to, but I might just connect up with a pre-registered question that's related to this topic, what we've just discussed. And I'll start with Lachlan. Lachlan, a pre-registered question is, in the coming times, would AI be able to predict a disease or health issue before it sets in? It's sort of related to what we were discussing.
Yeah, we're already doing it. So there is a commercial product available called Hypotension Predictive Index, or Acumen. It's published. It was originally built about 24 months ago by Edwards Life Sciences, which is now BD Advanced Patient Monitoring after they halved out the business. And this is a device that was built in acknowledgement that low blood pressure during surgery was associated with worse outcomes. And so this was a machine learning algorithm that took into account literally hundreds of data points from advanced hemodynamic monitoring waveform, so the arterial waveform, for example, and gave a warning to the anaesthetist or the critical care physician that hypotension, which was defined as a mean arterial pressure of less than 65, was about to supervene. and it told them what the likely cause of that hypotension was going to be, and then invited some strategies by which they could correct it. Now, there was a major problem with it. The device works very well. The issue is what I alluded to before. Just because you fixed the blood pressure didn't mean that you changed the outcome at the end. And so whilst HPI is probably the best example of early iterations of AI technology in the perioperative and critical care space, association is not causation. And so it's important that we keep trying to find intraoperative warning signs that are associated with real patient outcomes. So the work continues in this space. On a broader and perhaps less acute monitoring level, however, we are starting to see wearables enter into this space, particularly in terms of getting patients out of hospital earlier and back to their home environment where they're more comfortable. So you've had major surgery. Normally you would expect a 4 to 5 day stay in hospital just to make sure you're okay. But if you're feeling well enough, you go home with a wearable now that continuously monitors you as you convalesce and recover at home. And if there are any problems within the algorithm that indicates that you might be going to get a complication, or if there's an issue, it alerts the treating clinician back at the hospital that there's a problem and invites you to connect with them. Now, it's a very, very early stage in terms of development, and it's still about those two ideas about prediction and prevention. We're still working on what the outcome is that we're looking at, and we're looking at the intensity of monitoring as well. So it's already entered the critical care and perioperative space, but it does require some refinement with subsequent iterations.
Yeah, I might even add, there is a field, the field that I work in, which is computational physiology, where it is about creating physics-based simulations of biological systems. That sort of probably started when, if I went really historically, it started in the 1970s, and it's been growing since then. And it's interesting. There was a big push for patient-specific modeling, and we got to the point where we could create digital twins of an individual's heart, but it's still difficult to characterize that heart and then predict what it's going to do next. And AI has come from another angle. It's much more pure computer science angle, where it is a fantastic pattern recognizer and it can handle lots of data, but it is still a pattern recognizer. So I think there's an opportunity where these two fields should meld and get to that next stage of predictive algorithm development. Peter, another registered question I thought you might be great to address. I'm paraphrasing a little bit. I'm going to add a little spin to it at the end to be topical to the subject. My dad had an implant in one of his veins in his heart because there is a fat buildup. How, with current advancements in science and technology, is this preventable? I would want to say, how, with digital health technology, could we be preventable?
Yeah, BJ. So that sounds like somebody's had what we call a stent device, and it's normally implanted into the arteries, or if they've had previous bypass surgery, they can be implanted into the vein grafts. And these devices are used to open up the artery to restore blood flow when there has been a reduction because of this condition known as plaque or atherosclerosis, these fatty deposits. And these stent devices go in and act like a scaffold, like a spring, to keep the artery open and improve outcomes. They are life-saving if somebody's having an acute heart attack, and they can improve symptoms in those patients who have chest pain or tightness. Now, what we're doing, and that's particularly my area of interest as an interventional cardiologist, is that we are using AI, not so much because we feel that AI is better than humans, but because AI is actually much faster. So when we've put a stent in, we can analyze the stent by taking very high resolution images of this stent inside the artery, using this technology that we talked about earlier called OCT, or optical coherence tomography. It's a laser scan, and it gives us unprecedented information. Now, for me to analyze, say, a 18 millimeter stent in an artery, manually analyze and how it's functioning, takes me probably about 90 minutes. Using AI and with machine learning, we have been able to get that down to 19 seconds.
Wow.
So the speed that AI is giving us, I really see as a huge opportunity to be able to personalize treatments in the procedure lab, in the cath lab, whilst we're implanting these devices, and potentially learning how do we optimize them rather than doing it off label and after we've put the stent in and analyzing it, with our postdocs and our PhD students over the course of several hours or days. That's really where I think it's going to be a game changer. So AI improves our speed, and that will allow us to put this technology at the coalface, right in the clinical laboratory, in the ICU, in the cath lab, where it's needed most.
Lachlan, do you wanted to raise?
Yeah, I'd just like to add just a little grace note onto Peter's excellent summary of it. And he's described what, in my mind, is the ideal use of AI. So I saw something from a creative on social media recently, which is that I want AI to do my washing and my drying so that I can write my poetry. I don't want AI to write my poetry so that I can do my washing and my drying. So what AI needs to be is an interface by which the boring things that make up our lives are eliminated or made much, much faster, so we can focus as humans on the broader strategic implications of the technologies that we're bringing to bear. Put another way, AI should do one of two things. It should do something that humans are just not able to do, okay? Or it should be used as a labor-saving device for humans. And why is that? It's about clinician acceptability. You see online all the time people talking about how AI is going to replace Peter and myself. That is not an appropriate use of AI technology. It should free Peter and myself up to focus on you rather than eliminating us from the workforce. And if you can do that, it will massively increase the uptake and the acceptability by clinicians on the cold front. Peter and I don't want to be told that we're going to be replaced. We want to be told that we're going to be helped.
Yeah, that's fantastic. Vicky, I wonder if you want to add to that at all, because I do have another question for you.
You totally agree. I think AI, the ability of AI to compute and make decisions, as Peter has alluded to, that makes it quicker to make the treatment or to provide the information that allows treatment decisions to be made by the clinician. Absolutely imperative that the clinician is involved in that decision and is the final decider of the pathway that the patient needs to progress down, or the treatment that needs to be applied. But it does actually give us the ability to get those answers much quicker. I think that's the first thing. The other thing that we've seen with the ability of digital health technologies and using AI and big data sets is being able to identify things that maybe visually or in otherwise, if you look at, say, x-rays and the rise of the use of AI reporting in x-rays, is to identify things that aren't necessarily as easily picked up by people reporting on it. And that's not to do with the expertise of the reporters, it's just that it can do it better, right? So we've seen that with Harrison AI. So I think there's specific areas, and it's definitely not designed to replace clinicians, and clinicians need to be the decider of that end care, but it needs to help, as Lachlan alluded, and do those tasks that free them up to actually spend more time with patients and more time doing that personalised medicine, and that, whatever that looks like.
Yeah, and something that is hidden away in making these training data sets is the manual labor of curating the training data sets. So there's a ton of boring work to be done at the stage to get that data set that you think is going to help make good predictions. That is also kind of hidden away under the carpet.
I mean, if you look at some of the technology outside health, it's the same thing, right?
Yeah.
So I don't know if you saw the news last night, but there was an article on whale watching and technology that's being used to identify and locate whales. Well, it was used in the news. The news article was around whale watching for people to go and find whales, so it makes it easier to find the whales, so people actually get to see them. But in fact, developed so that we can help care for the whales and not have boats hit whales and other items in the ocean. Cargo I forget the word, cargo boxes and things that have fallen overboard. Great for finding people who are overboard, that sort of thing. When you set up that sort of software, you have to go through that training that says this is a whale, this is a boat, this is a person, or this is something else. So you've got all of that manual work that goes in to start with when you're training the model, but eventually you get to the point where you get them. Absolutely.
Hey, so this might be a question that it's an idea which is kind of interesting. So it's just, straight from the audience, and my apologies, I can't go through all of the questions. But the question from the audience is: could we use the equivalent of organ donation consent for de-identified patient data for research? Preferable opt-out system like our My Health record. So could you make data sharing or like an organ donation consent?
So I think an organ donation consent is a little bit of a misnomer, because it's more an expression of a preference. So with organ donation, you put down on your driver's license that you would like to be an organ donor, but that for you can be overrode by your family, because if you do end up becoming an organ donor, you're not usually you should never be in a position to be able to consent for yourself unless it's an altruistic donation. We are exploring in my institution adding this to routine surgical consent. So you, in the perioperative space, it's actually quite easy to do. You present to hospital, you're having elective or emergency surgery, you are required to sign a consent form, and there will be a tick box on that indicating that you're happy to use your data for research purposes. Now that leads to sort of a broader question around what are research purposes, and do we include sharing data with industry as part of those research purposes? That's, I think, a much broader question we probably don't have enough time to answer. But we did explore a long time ago the idea of opt-out systems, particularly around something around patient autopsy. So back in the 1950s, if you went to the Alfred Hospital and you presented, there was a little plaque on the wall next to the entranceway that said, if you enter this hospital, you consent for an autopsy in the event that you died. Now, obviously, that went the way of the dodo. People weren't happy with that in terms of the way that they were approaching this very thorny issue of personal consent. So I don't think current privacy legislation will allow for an opt-out system like My Health record when it comes to sharing your data with people who are not your individual treating doctor and who are not yourself. But there are ways around this, particularly in the perioperative space, and Peter might be able to speak as to whether or not it works in the cardiology space, that as part of routine consent, you would give your permission to use that data for research. What research means, not entirely clear at the moment, but this is a space that we're trying to use to increase the feasibility of using these data for these purposes.
Peter, would you like
question.
to?
A great point, Lockie. I guess it all depends on the type of research, doesn't it? And I guess having that sort of overall umbrella statement of yes, I consent. Well, I mean, a research can just be purely data collection, which, I'd be happy to participate in that. But there is also research that we are doing, putting new devices in that have not been, clinically approved. And I would perhaps like a bit more time to spend with my patient and discuss this and with their family prior to enrolling them in a study like that. So I think depending on the research, yes, there might be an option to participate in some data collection and de-identify data research. But in terms of interventional research and invasive research, I still think that requires a discussion. And I've been humbled by the support that patients give us. It's not often that patients that I go to and ask about, being involved in a particular study and trialing a new device. They are very, very forthcoming. They are very, very eager, and anything they can do to obviously get a great outcome for themselves, but also allow us to learn about, new iterations and improving technologies for future generations. I find them very, very eager to participate.
All right. I think we have time for one more question, and it's kind of heading us back to the AI topic, which is pretty much encompassing all of our minds every day at the moment. The question is, the FDA is evaluating AI to determine if cardiac deaths in clinical trials were due to test drugs or not. What is your perspective in AI making these decisions? Who would like to?
I can kick off. It makes me a bit uncomfortable, to be honest with you. And the reason I say that is that you want to know how well the model performs. So let me give you an example. In a recent trial that was run by our clinical trials network, we were looking at whether or not ketamine intraoperatively could prevent chronic pain. And in order to adjudicate that outcome, we had 3 chronic pain specialists review each outcome and the patient-reported data and make a determination about whether or not it met with the predetermined endpoint in the trial. Now, I don't see a problem with AI doing that as long as there is precise alignment with the clinician opinion and the AI model. Put another way, it's got to be right 100% of the time. Why do I say that? Because trials that look at these new drugs in clinical trials, they tend to be very small and they tend to be very fragile. One misjudged endpoint could be the difference between the drug being inappropriately approved or inappropriately rejected. It does not take many positive results, particularly for rare endpoints like death. It does not take many false positives or false negatives for you to reach the wrong conclusion. So without seeing the data as to how good the model is at replicating the opinion of the adjudicating clinician, I would be pretty keen to keep a human involved in that process. And we've seen this, haven't we, with the Doge cuts in the United States, where attempts were made to use artificial intelligence to make firings. And subsequent to that, they've had to hire back almost the entire workforce because they're using a tool for a purpose which it wasn't developed. So that's a cautionary tale. And I'd be keen to see the performance of this algorithm before I said it was appropriate or not. The stakes are very high.
Vicky, with the products that Hydrix Medical, delivers to its clients, what's the sort of process, or should I say, like the journey of going from, hey, we want to see if this device works in our clinic to, we're going to deploy it into your clinic? Is that a conversation that you have to go through?
In general, most sites, when looking at digital health, do want to trial it and have a look at the outcomes and the outputs that are coming through. They also, they don't want to see a black box kind of effect. They want to most clinicians would like to understand how the data is used and how the decisions are made inside the algorithms. So we often have those discussions. In general, trialing of the software is available, or alternatively, if other sites are using it, then peer conversations around using the solution. So it really depends on at what stage in the market you are and whether you're kind of first or 10th or 100th, and whether I think clinicians tend to like to talk to colleagues about using these sort of systems as well. So it really depends on what the system is, what the output is. But the idea of understanding what's in the black box, I think, is incredibly important, and comes out all the time. Yeah.
Is there? Do you think that the industry would value a third party doing that sort of work for, like, so you go to a client and they want to test things out? Is there room for university research to help with that as well, like that journey, that vetting of the algorithms?
I think by the time you're taking it to clinical, the clinical team, the vetting's kind of already been done. I think where research and where universities can come in is coming up with these data sets and these algorithms, and also looking at the use cases for some of these areas. If we look at, say, heart failure, for example, as a major issue in our healthcare at the moment, because people are living longer and heart disease continues to increase. Areas of research around how we can better approach or better predict or use early symptoms to better predict outcomes, or help provide more information for those algorithms. I guess that's where research in university is really good, because you've got the time, you've got the manpower, you've got the interest of the researchers, and you can look at a bunch of different models and different disease processes. And then if there's something that comes out of that, then taking that and looking at how that might be commercialized or used, rather than looking to test existing solutions, I suppose. Yeah,
fantastic. Folks, I'm really enjoying. I feel like now I'm really deep in the conversation, but our time is up. So, unfortunately, our time has come to an end. And on behalf of the MedTech platform, the Graham Clark Institute, and the University of Melbourne, and personally myself, I'd really like to thank all my three panel members for giving us the time today and for really sharing a very enjoyable conversation with you all. Thank you so much. I really appreciate it.
Thanks, BJ. Thank
Pleasure. Thank you.
I also want to thank our illustrator, Alice. I've been following briefly all the cartoon illustrations she's been doing. It's fantastic. I thank you for capturing all of our discussions and learnings, Alice. I would also like to thank our audience members for your questions and the interest in attending this webinar today. We'd appreciate your input on our post-event survey, which is located at the bottom of this video stream and within the Q&A chat box. We value your feedback to help us shape the future of our MedTech webinar series. Thank you, everyone. Stay safe and have a nice day.